Well, thank you very much. Can everybody hear me? Do I sound okay? Well, first of all, I have to say it's absolutely fantastic to look out and see so many people here today who are interested in a topic about older people. Even coming out in the rain and at night to hear a topic about older people and hearing even particularly about depression. It's a subject that I care a lot about, but the reason why I'm really thrilled about this is because we don't think enough about our aging population. And you may or may not be aware that those of us who work a lot with older people, and I'm a geriatric psychiatrist, we often talk about how we are really at the very beginning of what we call the tsunami of aging. And that, the word tsunami will be very relevant to you because we hear it a lot in the weather. But what we mean is that we're at the beginning of a huge demographic change in our country, whereas when we had the United States National Census in the year 2000, about 12% of the population was over the age of 65, and 10 years later, in 2010, it really hadn't budged. It was still about 12, 13%. However, over the next 20 years, that's going to skyrocket, so that by 2030, 20% of the population is going to be over the age of 65. And that means for those of you who are practicing clinicians now, who take care of individuals of all ages and of adults, over the next 20 years, a greater percent of the patients and clients that you take care of are going to be senior citizens. And for those of you who are aspiring to be working with individuals in some sort of helping profession, well, you're going to really see this in the course of your career. And yet we really are not doing enough to train future clinicians and people what it really takes to be able to take good care of older people. So I'm going to be talking today about depression, but even before I begin, first of all, I have to say that old age is not synonymous with depression. And in fact, most people age and through all the ages of life and they don't become depressed. So that whenever we see depression, we consider it is not a normal part of aging. I think that's really important because a lot of people may feel in their own, in your families or people in the community, well, once you get older, you have this medical problem, this disability, these limitations, maybe depression would be considered normative, and it is not. So tonight I'm going to talk to you just a little bit about recognition of depression. I'm going to talk about some of the ways particularly that depression in older people is different than in younger adults and other people. And then I'm going to talk about the approach to management and really stressing at the end a little bit about suicide and how we think about that because it's very relevant for older people. So the first question is, well, I just told you that not everybody, becomes depressed when they get older. How common is depression in later life? And you might think that's a very straightforward question, and it is, but the answer is actually very complicated. And it depends, number one, how you define depression, and it depends, number two, where you look for it. And about 30 years ago, there was a very important epidemiologic study that was done in 5 big centers here in the United States, where they sent out trained lay individuals to interview adults in 5 different cities over the age of 18. And a total of 18,000 individuals were interviewed, which is a huge number. This study is so large it's never been replicated. What was remarkable from that study is that rates of major depression, which is the most serious clinical form of depression that we treat, were much lower in older people than younger people. So I'm going to show you this in this little table. Major depression, that's that first column. Community dwelling, that just means people who live at home. They just answer they answer the door when somebody comes to interview them. 1 to 2%. If we right now could magically send out interviewers across the country to just knock on the door of every adult over the age of 18 and do a good assessment, we'd find about at least 5% of the adult population right now has a significant major depression. So right away, this was really surprising. Why does that mean that the numbers are low? But you're going to notice that it depends where you look for it. For individuals who are in primary care clinical settings with doctors, the numbers go up to 10 to 12%. Individuals who were hospitalized, this is not psychiatric hospitalization, this is just a general medical hospitalization. It's even higher, and the rates are higher in nursing homes. But then you see this column I have here on the right, and you're probably wondering, well, what does that mean? What is this thing, which is subsyndromal depression? So there's a condition of where you see the rates are even higher, that there's a condition of subsyndromal. I'll tell you what that is in a minute. A subsyndromal depression, and the rates are significantly higher in all settings. And again, they're the highest of all for individuals who are in nursing homes, and where the rates go up to 30 to 40%. So what is this? Well, people have called it different terms, and sometimes it's called minor depression, sometimes it's called non-major depression, and basically it means a form of a serious depression that doesn't meet the full criteria for major depression. It always includes a low mood or losing interest, and a loss of interest meaning not getting pleasure from things that normally would give you pleasure. And in addition, including at least 2 other symptoms: a change in weight, usually losing weight, people lose their appetite, sleep, usually not having more difficulty falling and staying asleep, motor activity, usually feeling more slowed down, low energy, poor concentration. And all of these aspects are all part of major depression, but for this minor depression, you don't need as many of them. So the interesting thing about this is that actually the most common mood disorder in older adults is not major depression, but it's the subsyndromal minor depression. The name minor depression, though, is very misleading. You'd think it means, well, that can't be that significant, and actually, it's very significant. About a quarter of individuals who have this subsyndromal depression will, within 2 years, progress and get even more depressed and meet every psychiatrist's criteria for major depression. But even for those who remain at a subsyndromal diagnostic level, it affects their functioning, their quality of life, and actually we're really beginning to feel that it's on a continuum with major depression. We're really not talking about a different entity. So it's been of interest to a number of people, well, if we can recognize subsyndromal depression, can we intervene? Can we do something when it's at this level to prevent it from progressing and becoming major depression? And so this very interesting study was done just a couple of years ago, and that was exactly what they wanted to do. And they had a very interesting approach. They looked at people over the age of 70, and they already identified they had this subthreshold depression. And then they divided them into 2 categories. Some got what they call usual care, which means not that they ignored them, but that, if they need whatever help they needed, they came to their doctor, their nurse practitioner, whatever, they would address their issues. But the other half, they had a very regimented, specific plan, and this is might be a little bit small to see, but every 3 months they reassessed these individuals, and for those who had subsyndromal depression, the first thing they did was teach them some self-help kinds, kind of self-help approaches, things they can do to sort of cheer themselves up, exercise, that kind of thing. And that might be the first 3 months, and some people got better with that. And if they didn't, then the next 3 months they would reassess them, and then they would teach them something called problem-solving treatment, which is a psychotherapy approach to solve your problems. And if that didn't particularly work, then they would refer them to the primary care physician, who then would probably prescribe an antidepressant. And what they found is at the end of 2 years, those individuals who did not get this special stepped kind of treatment, well, a good percentage of them are here, and they got worse, and they really had major depression, whereas these individuals down there were less likely to have major depression. So it looks like this can be very useful. So recognizing subthreshold depression is useful, because if you intervene, maybe you can really prevent people from becoming more depressed. This is an earlier study that really just helped teach us that subsyndromal depression is on that continuum with major depression, because these were patients in primary care who had subsyndromal depression, and they received paroxetine, which is a standard antidepressant called a selective serotonin reuptake inhibitor, or they might have gotten psychotherapy, and some got a placebo. And those individuals who really got the antidepressant did much better. Particularly, it was beneficial for those who were really the most impaired and the most depressed. We worry about depression, particularly in our older patients, for a lot of reasons. Of course, it affects the quality of their life. If they're not enjoying things, if they're slowed down and they're not sleeping, they're losing weight, all the kinds of ways that depression affects individuals. But a lot of older people have medical problems at the same time as depression. And the important point is that whenever those individuals are depressed, it always has a negative interaction for their medical problems they're also experiencing. So if they're depressed and they've had a hip fracture, an MI stands for myocardial infarction, that's a heart attack. If they've had a heart attack, they've had a hip fracture, they don't recover as well. They have a slower recovery. If they're in the hospital for any reason, pneumonia or any kind of congestive heart failure, you name it, GI problem, they tend to stay longer. After they get discharged from the hospital, they're less likely to follow the doctor's or nurse's recommendations, and they tend to use a lot more healthcare resources because they're just feeling so poorly. So depression has a negative impact on other medical conditions. It also has an impact on mortality. The next slide is kind of complicated, but it's incredibly interesting. So this was a study where they followed, it's about 500 individuals over the age of 50, and they were in 3 different categories. A third of them were cognitively normal. They had no memory problems. A third had mild cognitive impairments, some mild memory problems that might have been harbingers or the early beginning of a dementia. The final third were individuals who clearly had a dementia, a severe memory problem. And then they followed them for 12 years. And some of those individuals were depressed at the beginning and some weren't. And what they found in every category, if you were depressed, they had a higher risk of mortalities, which is really interesting. So this is, let me see if I can show you what I mean by this. This is called a survival curve, and it shows how the percentages of people who were alive at the end of 12 years, and you can, there were a lot of deaths, but these people here had the best survival curve, the one in red, and those were the individuals who had no memory problems, they were cognitively intact, and they weren't depressed. Makes sense. But you would think maybe the next group would be those individuals who had mild cognitive problems, but actually that's not true. This blue line here are those people who had mild cognitive problems, but they weren't depressed. And this line here are those individuals with severe dementia and weren't depressed, and they had better survival than the green, purple, and orange lines. And the green line here are the individuals who had normal memory, but they were depressed, and their mortality was worse than the other 3, even the individuals with severe memory problems. And it's no surprise that the individuals who had the highest risk for mortality were the ones who were depressed and also had dementia. So depression is a risk factor for mortality. What about depression? Is it a risk factor for dementia? And it turns out that it is. This is a study of a very famous study, the Framingham Heart Study, where individuals with depression were followed for 17 years. Those who were depressed towards the beginning of the study, over 21% of them developed dementia compared to 16% of individuals who didn't. And we actually now recognize that late life depression is sometimes an early symptom of dementia too. It can be even an early symptom of Alzheimer's disease. So depression does a lot of things, increases risk for mortality. It seems to also be a risk for dementia, and it also worsens medical problems. So how do we pick it up? What are the symptoms? This is a table that lists symptoms of depression, and I have to tell you that we don't have different criteria for diagnosing depression in older people for a 70-year-old compared to a 30 or 40-year-old, or even a 21-year-old. However, a lot of the symptoms are the same. We see changes in sleep and appetite. As I said before, usually difficulty falling asleep, not being able to sleep through the night, waking up too early at 3 or 4 in the morning, and then you can't go back to sleep. That's classic. That's really common for serious depression in all ages. Losing weight due to a poor appetite, diminished sex drive happens at all ages, poor energy, lack of motivation, feeling worthless, feeling bad about yourself, feeling guilty for things you shouldn't feel guilty about, difficulty concentrating, making decisions, irritability, restlessness. These are all similar. What's a little bit different in older people are the last 2. I'm going to come back to this, which is memory problems. Having memory problems, which actually can be reversible when the depression is treated, is very common in older people. And vague somatic complaints, that means physical complaints relating to the body. We see more of that in older people than in younger people. So I've told you that we really don't have different criteria, but I will say that what I see, even amongst psychiatrists as well as fantastic good clinicians, doctors and nurses, is difficulty really recognizing depression. And you might say, well, those should be obvious. There's so many of them. Why is it difficult? And it's difficult for a couple of reasons. One reason is this something called this medical comorbidity, the fact that older people have other medical conditions. In a 25-year-old or a 30-year-old, if their energy is really low and they don't feel like going out, well, you're gonna say, whoa, that really, that's unusual for a 25-year-old or a 30-year-old if they just want to stay in bed all day and they don't feel like going places. In a 70-year-old or an 80-year-old, you might say, well, maybe it's due to her arthritis, or maybe it's due to his congestive heart failure and his heart condition. You might be more likely to think that's due to the medical problem, so that can complicate the picture. Sometimes, we often talk, these are called vegetative symptoms, refers to things like difficulty with sleep and appetite, so there could be due to many different causes. The other reason is that a lot of older people don't necessarily say they're sad. In fact, they might really focus more on a physical complaint. A patient I had that had frequent recurrent depressions, when she was depressed, would focus on her GI system, and it would always be off, and she'd have a lot of abdominal pain, or she'd have belching, or she'd have all kinds of problems. She wouldn't necessarily say she was sad, so she was constantly going to a specialist and to a gastroenterologist. It turned out that that really was an expression of her depression, and it went away when her depression got better. And this last one I'm going to talk about because this is really important, which is a lot of older people, when they get depressed, look like they're cognitively impaired. And they can look like they have a dementia. It is not dementia like Alzheimer's disease. I'll tell you how it's different. But because that can be so obvious and so blatant and glaring, sometimes that becomes the focus of attention, and people don't realize it's part of depression and think that it's really the beginning of Alzheimer's disease. The way that I tell it apart, if I see an older person who's having difficulty with their memory, is through a couple of things. One is that a very key symptom of depression, which actually is more reliable than sad mood. You think sad mood should be the most obvious thing, but even at all ages, the best indicator for depression to me as a psychiatrist is a term called anhedonia, which is a loss of pleasure in things that normally were pleasurable for you. So I will see in an older person, doesn't want their grandchildren to come by. Always loved the grandkids, always had a great time when they came, but now they get on their nerves. Or they don't want them to come. When they come, they want them to go. That's so, because it's no longer pleasurable. Or eating favorite foods are no longer pleasurable. Doing things that they used to enjoy, going to church or going to activities are no longer pleasurable. In an individual with dementia, they also may lose interest, but they just don't care. They just don't care anymore about playing cards, usually because it might be frustrating for them, and they're not so interested in doing it. But it's this loss of pleasure and enjoyment that's very different, and it's very characteristic of depression. The other thing is that when you do sort of memory testing, standard memory testing with an older person who's depressed, they'll frequently give up. They'll say, oh, I'm not even going to try that question. That's just too hard for me. Whereas in an individual who has a dementia will try it and just get it wrong, and often not even recognize they gave a wrong answer. Onset of symptoms, there's very few things that can change somebody abruptly. If I hear about a story of an older person who was suddenly markedly different, and really suddenly like over weeks or something like that, rather than over a couple of weeks or a month or so, I'm going to be really worried about depression. Dementia just never happens abruptly, unless somebody has had a sudden stroke, and then that would be obvious because they would probably have paralysis or weakness. It's usually gradual. And then variability of symptoms. Classic for depression in all ages is something that we psychiatrists look for, which is something called diurnal variation. It's very often it happens that the mornings are the worst time of day for people with depression, young and old. They have so much trouble getting up in the morning, getting themselves motivated, but sometimes feel a little bit better as the day goes on. That's a symptom of depression. Whereas an individual with dementia actually tends to get worse as the day goes on. In fact, the term has come sundowning, meaning when the sun goes down, that individual gets more confused. What about treatment issues in depression? So depression can be hard to manage, can be hard to recognize, but sometimes people, even when they recognize it, don't necessarily get treatment. And I often see two interesting phenomena happen. One is I see among patients themselves or their family members say, well, this can't be a serious depression because you'd be depressed too. You'd be depressed too if you just went into the nursing home, or you'd be depressed too if your kids just told you you could no longer drive, or you'd be depressed too if you had to walk with a walker, or you'd be depressed too if you had Parkinson's and had a tremor. Because it's understandable, people often think it's not serious. But I've often seen the absolutely opposite one, like, this can't be a serious depression because everything's going great in her life. How can she be depressed? She's got no money problems, her health is good, the grandchildren are doing well. You know what I'm saying? It's kind of amazing that both opposites lead to the wrong conclusion. And the reason why people get that conclusion is they don't look for the syndrome. Depression is a syndrome. And if you see the syndrome of depression with a combination of symptoms, you have to diagnose it whether there's a meaningful cause or not a meaningful cause. It's actually cause is irrelevant. The other thing I often see is insufficient dosing. It's very important for older patients to start at lower doses of medication than we would give to a younger person. However, a tiny dose is a great starting point, but you never keep somebody at that tiny starting dose. They could stay at that tiny starting dose for years and they'll never get better. It has to be an adequate dose, and the final doses are often the same in an 85-year-old as a 25-year-old, and people often don't know that. And then premature discontinuation at all ages. A big problem for not overcoming depression is stopping the medication too soon, or thinking that what you're experiencing is a side effect of the medicine when really what you're experiencing are the symptoms of depression that haven't remitted because you haven't been on the medicine long enough. So sticking with it is really important at all ages and really important for older people. So how do you screen for it? And for those of you who are doing primary care right now, I think a really, really helpful way in a very busy primary care setting is to use a standardized screening tool to just come prepared for that. And there's something called the Patient Health Questionnaire that's very useful. The PHQ-2 just asks 2 questions, which is really good, and just really says, well, over the past 2 weeks, how often have you been bothered by a low or depressed mood, and how often over the past 2 weeks have you been bothered by a loss of interest and pleasure in things you used to enjoy? Those answers to those 2 screening questions will let you know whether you need to pursue it further. And if the scoring, you can look it up on the internet, or I can tell you how to find it. If the scoring has to do with whether it's never happens at all, a couple of times a week, or almost every day. If it's pretty much every day, that would be a level 3. If you get a level 3 on that PHQ-2, you have to ask more questions, and that would be the PHQ-9, which includes the first 2 plus 7 more. And it's a really good screen because it really asks the classic symptoms of depression, and an individual who scores greater than 10 probably has major depression. The other advantage of it is that as an individual is getting treatment, you can use this over time serially to see how they get better, and you should see the score go down as they're getting better from the medicine. So it kind of corroborates what your clinical assessment is, which can be good. So I talked to you about the fact that older individuals can seem like they have a dementia, and a really vivid patient that I once took care of, actually, this was incredible. She recognized in herself she was starting to have difficulty taking care of herself. She had difficulty with the checkbook, she had difficulty making meals. She decided for herself that she must have a dementia, and she signed herself into a nursing home. And one of our geriatric psychiatrists happened to be making rounds at that nursing home and saw this woman and realized she didn't have a dementia, she had depression, had her hospitalized on our inpatient service. She got treated in a very standard, straightforward way for major depression. She got so much better, she signed herself out of the nursing home. She didn't need to live there anymore. But what happens to individuals who are older, who have a serious depression, is this type of cognitive impairment. I told you it's not the same as Alzheimer's disease. Alzheimer's disease is a problem of forgetting. People can't learn new information and they forget it. What happens with individuals who are older and depressed is something called impairment in executive functioning. Executive functioning is what our frontal lobes do. They're right behind your forehead. The frontal lobes enable us to plan, organize, make priorities of things that we want to get done. It's critical for life. And obviously you need it when you're a student, you need it when you're a professional. When it's impaired, it affects something called IADLs, instrumental activities of daily living. So what does that mean? If you can't organize, plan, and prioritize, well, you're going to have difficulty organizing your medicine. You're probably going to make mistakes. You're going to have difficulty paying bills. I've seen patients where the envelopes of bills pile up. They just don't have the wherewithal to figure out which to do when and how to pay it, and they don't pay their bills. You're going to have difficulty making meals. Making meals requires a high level of executive functioning. As everybody here knows, you've got to think about what you want to eat. Do you have the ingredients? You have to shop for them. If you're going to cook a couple different things, they're going to get done at different times. You've got to monitor this in the microwave, this on the stove. Very complicated. I had an older woman who had a very serious depression. When she got depressed, her husband lost 40 pounds because he was relying on her to cook. She lost some weight too. She lost weight too, but it put his health at risk because he didn't know how to cook. And she wasn't cooking anymore because of her executive dysfunction. The good news is, if you recognize it and treat the depression, this gets better. And depression is one of the few reversible causes of cognitive impairment in older people. But you have to recognize it, and then you have to help support the individual. So I always ask questions of my older patients, how are you cooking the meals? Who's doing the shopping? What about paying bills? And make sure that I bring in resources and help, usually engaging their family, or if there isn't family, there are things like ordering Meals on Wheels to bring nutrition to individuals so that they can eat. Finding ways to someone to come and help organize their pills so that they don't make mistakes until they get better. What about psychotic depression? I just want to say a word about this. So psychosis or psychotic symptoms refer to hallucinations and or delusions. And hallucinations are responding to a stimulus that isn't there. Hearing voices that nobody else hears because there are no voices. Seeing things when there's nothing else there. That's not so common in older patients who are depressed, but some older patients who are depressed have psychotic depression, and then they very commonly have delusions. Delusions are fixed, false, idiosyncratic beliefs. Fixed because you can't talk them out of it, as illogical as they are. False because they're blatantly wrong, and you usually have to talk to a family member to really be sure about this. Idiosyncratic meaning they're particular to the individual. It's not a cultural belief. So what you might see, a common psychotic delusion or in an older person is the belief that there's something wrong with their body, that they have cancer, that something's not working right. And so that might actually send them to multiple specialists. And individuals often go with these somatic delusions to multiple doctors who might do all kinds of workups until they realize that this is a delusion. Another really common delusion in older people is a delusion of poverty. I had a patient of mine, when he became really depressed, he believed he was poverty-stricken, that he believed he was going to be thrown out into the streets. He believed that he had in his house, he had a tenant. He thought that the tenant was going to be thrown out. And when I talked to his son said, no, Dad's got plenty of money. There's not a problem with his house. It was a delusion. That same individual developed a somatic bodily delusion that he couldn't move his bowels. And as incredible as it is, even though they were moving, he said that they really weren't moving. And he believed he hadn't had a bowel movement in 3 months, which sounds funny, except he was tortured and agonized over it. So it's very important that these questions be asked, and if there's a concern that there might be a delusion, that you might have to corroborate, with a family member to find out about it, because psychotic depression requires specific treatment. So what is the treatment approach? Well, pharmacologically, for those of your clinicians, this will be obvious to you or familiar to the fact that these days, the first line, what we turn to first, probably for depression in all ages, and particularly for older people, is a class of antidepressants called the selective serotonin reuptake inhibitors. They're generally well tolerated. There are a lot of them. We start at a low dose and gradually increase. Again, remembering you've got to get to a good final dose. There are side effects. Some people develop some transient nausea and some looser stools. They can get a little bit of a hand tremor. We have to watch for watch the sodium level, which can be done in a simple blood test. Occasionally that can drop with these medications. If it happens, it can cause confusion. But once somebody gets well, and you have to really follow them week after week and be in touch with them because all antidepressants take 4 to 6 weeks to work. This is one of the things that's the most incredible thing to me. The very first antidepressants were available on the market in the 1950s, not before that, by the way, which is really incredible to think that we've been recognizing depression in all ages for thousands of years. but we never had antidepressant medications until the 1950s. And in fact, I'm really lucky that I have the medical school notes from my grandfather, who was a general practitioner. He wasn't a psychiatrist, but I have his psychiatry notes, and he graduated from Creighton Medical School in 1933, and his notes actually have a fantastic, absolutely accurate description of how to recognize depression, the same way I teach to my medical students today. But when it talked about treatment, treatment was this big in his handwritten notes, and said, number one, prevent suicide, and number two, force feeding for those who wouldn't eat, and number three, try to give hope and care. That was all that could be offered. So now we have antidepressants, but from even the very first one that was available in the 1950s, they all take 4 to 6 weeks to work, and even the newest antidepressants that came on the market in the past year, 4 to 6 weeks to work. ECT, electroconvulsive therapy, yes, we do it. It's very effective, and sometimes it's the most effective way of treating a psychotic depression in an older patient. And psychotherapy is very important in order to give people a sense of hopefulness, particularly in the early weeks before they see improvement. TMS you may have heard about, repetitive transcranial magnetic stimulation. It's a new therapy. We're starting to use it at Hopkins. So far it seems to be useful for more milder depressions, and maybe the results so far are better in younger people, not so great so far in older people. A big concern is adherence with treatment in all ages, and a lot of studies show that non-adherence to depression is up to 60% in older people. So you can imagine if you don't take it, obviously it's not going to work. So it's very important that individuals get seen and get lots of encouragement to stick with the treatment. So I want to talk a little bit about geriatric suicide, and because it's a real concern. This is an interesting graph that shows really rates of suicide are different depending on age and gender, and actually also race. And this shows you here different ages, what the rates are, and you can see that for men, this is for African American men and white men, there seem to be two peaks. One in kind of early life, and then another peak later in life. But look at this. This is the highest rate, this blue one, and these are older white men. And look how the rates skyrocket, and you're not going to believe this. Here, over the age of 85, the rates are the highest rates in older white men. They actually are lower in women. The green are white females, and then African American females are the lowest in yellow. So suicide rates are high in the elderly. They're higher than you would expect even for the population, and the highest rates are largely due to men, where the risk really increases with age, and the highest over the age of 75. This is a little bit of encouraging news for those of us who have been taking care of the geriatric population, because this is the rates of older people, which actually since 1990 have been coming down, but they're still incredibly high. These are people kind of in, it's such a big category. It's ages 25 to 64, but actually the middle-aged group, like from 45 to 65, those rates are now going up a little bit higher. But so why do we worry about this? Well, younger people make more suicide attempts, but among the elderly people, they make more what we call completed suicides, and the reason why is they tend to use more lethal means. Younger people are more likely to do an overdose with pills, and it's easy to miscalculate, thank goodness, with pills, and you might be very sick, but you're not going to die. But this is incredible. Look at this. Over 70% of geriatric suicide is due to firearms, and that's in men and women. And you don't have to be skilled with a gun to successfully kill yourself the first time. So anytime I have a concern about a possibility for suicidal thoughts in an older person, you have to ask, do you have access to a gun? And if so, I make sure that I contact a family member to say, this gun has to go out of the house, even if they're not thinking about it right now, because the suicidal thoughts can come at any time, in the course of a serious depression. Suicide actually is very difficult to study, though, because ideally the best way you'd want to study, well, who's at risk for it? You want to do a kind of a study called a prospective study, where you take a group of individuals and follow them into the future. And at the starting point, you can get lots of data on their characteristics about who they are, and then see which one of those characteristics in the future was predictive by seeing how many people attempted suicide in the future. But because the rates are actually relatively low in the population, it's incredibly difficult to do. There are very few of these prospective studies. So most studies have been done by first identifying people who have already committed suicide and then going backwards, trying to do detective work, looking at their records, talking to doctors and family to say, what did we miss in the clues? And when those are done, we find that significant factors are often social ones, such as stress. Bereavement is a very big stress, lack of family support, and really living alone is a particular big stress. We often worry about the older man who has become a widower, living alone, disconnected from family. Medical illness also seems to be a risk for suicide. This was a study of the province of Ontario, and they looked at all residents in that province in Canada over the age of 66 who had committed suicide over this period of 8-year period of time, and try to connect it with the number of prescriptions they had for medicines as a way to kind of get at their number of medical problems. And they found remarkably, those who had 3 illnesses had a 3-fold increase in relative risk, 5 illnesses, a 5-fold increase. And this is really showing you kind of the more prescriptions and illnesses you had, the greater your risk seemed to be related. And particularly at risk were if you had had depression, that's not a surprise, but also if you had a severe unremitting pain disorder. Primary care, though, is really the ideal way to identify suicide risk because most older people are going to be seen by their medical doctor or their nurse and not by a psychiatrist. And a lot of older adults with mental health issues are seen in primary care settings. One of the studies, multiple studies have actually shown that an individual who has committed suicide, 75% of the time they've seen their primary medical doctor or clinician within 4 weeks of the suicide. So really, this is so important for anyone who's going to be doing any kind of clinical care to have a sense for. What makes it tricky in talking about and assessing suicide in older people is a number of things. One is you have to feel like you can't worry that you're going to be disrespecting the older person to ask. You just can't. It's really clinical and it's a form of caring. The second point is anytime you work with an older individual, you have to feel comfortable with the fact a lot of older people are thinking about death in a normal way. That's going to sound strange. So how can you figure this out? So as people age, thinking about death can be normal. I often tell the story of my husband who spent a couple of summers when he was in college living with his 82-year-old great uncle while he was doing a nice internship, and every day the uncle would turn first to the obituary section of the newspaper, and he wasn't depressed, he was just looking to see, because very often he might know somebody who was on that page because they were his peers and his age group. And I see this among a lot of my older patients too. There's a sense that thinking about time, well, I has had a patient of mine recently, she turned 90, and she had a lot of trouble turning 90, and turning 90 was only a day over than 89, but for her 90 meant, well, my life has now moved on to, and I've got less of my life ahead of me than I have behind me. It wasn't necessarily depression, but just thinking normatively about death. Thinking about it is very different than wishing for it. Wishing for death is never normal with aging. And so that's called a passive death wish, when somebody feels so bad, they feel like if they were to die in the middle of the night, they would actually welcome death. That if it were to happen to them, that's a passive death wish. And that, of course, is different than an active thought where someone has an actual plan of what they're going to do. Interestingly, an individual who has ever made a suicide attempt at any point in their life, that increases their risk for suicidal behavior even decades later. So when I take a careful history of a patient, if I learn that there had been a suicide attempt in their 40s, I'm going to say, well, that person, even though they're 70, they're at even higher risk than a 70-year-old who never made a suicide attempt in their 40s. So how do you do it? Well, you have to directly ask about it, actually. People are not going to spontaneously tell you about their thoughts. But a really important thing to know about asking about suicide in all ages is asking about it never increases the risk that the person's going to follow through. This is so important because when I teach our medical students this, I really want to make them feel comfortable about it. Time and time again, when I talk to individuals who have these kinds of thoughts, it's a relief to share it with somebody else because almost all of the time the individual is ambivalent. They're having these thoughts, but they really don't necessarily want to act on it. It's a relief to share it. The PHQ-9 that I mentioned earlier is good because the 9th question asks about suicide. But if a patient ever flags it, you have to follow up on it. And the way to do it is really in a structured way. So here's my suggestions about what to do. I think first you want to, in an interview, sort of find out, is this person having what we might call normal thoughts of mortality? Life is, less of life is ahead of me than behind me, but they're not wishing for death. Well, if that's the case, they're not suicidal, but you might, if you're their doctor or your nurse or their therapist, you're going to want to follow up on it periodically. If the individual, though, is having thoughts that life is not worth living and agrees to that, then you want to find out, well, you have to pursue it and find out they're having any thoughts of harming themselves. Are they having any specific active suicidal thoughts? And certainly if they are, that requires additional questions. And I ask very specific questions. I will ask very specifically, well, tell me specifically, what have you been thinking of doing? Have you thought of a specific means that you might do? And if so, how often have you had these thoughts? How often have they come to you? How persistent are you? And again, I'm more worried if I hear that somebody's having these thoughts more often. I'm more worried if I hear they can't dismiss them even if they don't want to. I'm more worried if I hear they're in their mind a lot of the time. I will then ask, how close have you come to these thoughts? Because sometimes people who are thinking, well, I don't really want to do it, but I'm feeling so bad, I've thought I might take pills. Sometimes they practice. They say, well, I've emptied the bottle in my hand, but then I put it back. Well, I'm more worried about someone who's taken that step. That makes me even more worried. And I might ask, would anything prevent you from acting on these thoughts? And some people will say, absolutely, I have these thoughts, but my religion forbids it, and I would absolutely never do it. But recently I had someone who said, my children would get over it. I said, really? Your children would get over it? And the person, oh, sure, they'll be sad for a while, but they'll get over it. I was really worried about her and really took action on that. So someone who has passive ideas, we might recommend you follow up on them within a week, and certainly, and even after starting an antidepressant, we continue to ask about suicidal thoughts, because sometimes in the early weeks before the medicine has really kicked in, those thoughts can actually appear. If someone is having active thoughts of a specific plan, then they really need to be seen by a specialist, a psychiatrist right away, and probably sometimes even they need to go to an emergency room for an immediate assessment. It's really helpful to know that antidepressants are effective in reducing the risk of suicide in older patients. This was a study that really showed that antidepressants are effective for not only improving well-being, but improving risk of suicide. And this was one of the few prospective studies that tried to assess suicidal thoughts, and they focused on 20 primary care practices, and individuals were randomized. Some of them had what's called usual care. They saw their doctor or nurse regularly. The others were working with a specific depression manager who made sure that if they were depressed, they got a medicine, made sure if they got the medicine that they got it filled. If they got it filled, made sure that they took it. If they had a question, they got it answered. And those individuals who had that closer follow-up had less depression because they had a better relief from their depression, and suicidal thoughts went down. So to kind of summarize, and it's been a kind of a packed hour, but sort of summarize what I've been talking to you about. Depression, especially this subsyndromal depression, is actually common in older people. And it needs to be recognized because it negatively impacts functioning and well-being. It has an impact on what we call comorbid medical problems. It increases risk for mortality. And that really honing in on this idea of anhedonia, loss of interest in formerly pleasurable things, looking for this diurnal variation where mornings are terrible and people's symptoms get a teeny bit better later in the day, and abrupt onset, and executive dysfunction will help distinguish it from dementia. And to remember that treatment strategies are similar as to younger people, but medication non-adherence needs to really be addressed. And that really working together, I think, is really with psychiatrists, mental health specialists, and primary care physicians is really the way to go. So thank you very much. I tried to leave a little bit of time for questions. Thank you for being here and for listening. Okay, so the question was, there is a very popular scale to assess depression called the Geriatric Depression Scale. What people like about it is that you can give it to the patient themselves and they fill it out. So it saves a little bit of time. It's something a patient can do. I think for me, the negatives of it, even though it's easy to give and patients give yes, no answers, the thing that, there are two things that I think make it less useful in primary care than the other one I mentioned is because it doesn't ask about suicide. There's no screen for that. And I think it's just, I think an evaluation of depression isn't complete at all ages without asking for it. And I think you might miss people who wouldn't necessarily spontaneously tell you. And secondly, if you're working on on an ongoing basis and you're starting a treatment, the Geriatric Depression Scale isn't good as a measure of how well they're getting better. So you can't have it as that kind of that follow-up. It's often used, like in health fairs. It can be kind of a good first step. If someone's just coming to a general health fair, it might flag people who are suffering from depression, but then you'd want to follow up on them and do a little more thorough assessment. Yeah, you had a question. Screening which patients, did you say?
Patients right now we're focusing on patients with diabetes. A lot of our population is diabetes. What we do is order patients. And I was just wondering, do you have any perspective on, the pharmacist's role in all of this collaboration on care prevention? Would you, as a practitioner, want to receive from a pharmacist the results of the screening? Would you want to receive a recommendation based on those results?
Okay, so the question was about the role of a pharmacist in collaborative care for an older person, and you specifically mentioned diabetes, and I'm really glad you did because I think the study showed that maybe 18% to 20% of individuals with diabetes get depressed, so there's something about that condition that increases the risk. Boy, these days I think the role of a pharmacist is more important than ever. Because one of the things that's really happened that I've seen over the past 10 or 15 years, probably the average older patient is on 6 to 8 different medicines, 6 to 8. And many of my patients are sometimes on 15 different medications. So the possibility for interactions between them is high. And sometimes the medicines themselves can be causing problems, and to have the input of a pharmacist who's really an expert at medicines I'm not an expert at can be incredibly helpful. And sometimes I might want to, as the psychiatrist or maybe the internist or primary care clinician wants to add an antidepressant, the pharmacist can help us be aware of potential interactions and things that we particularly want to monitor on that might be at risk for some changes in the heart rhythm and things like that. So I find that incredibly helpful. I'm very grateful to the pharmacists who work with us. Well, I think any way that people get screened is fine. It's not the screening that's I'm concerned. Is how is it going to be handled? Will the pharmacist be able to do the follow-up? And what happens to the person who screens positive? Then what? I mean, if there's a good plan, yes, but screening by itself makes me nervous if there isn't a good plan for then what happens next, so that people don't fall through the cracks who need to be identified and get into treatment. Yeah, yes.
Could you expand a little more on the non-pharmacological approaches that
Right. So in older adults, there's been a terrific evidence, and this is true really for all adults, of the importance of exercise. I think that's incredibly important at all ages, getting people mobilized and getting them up and out. Having a schedule and getting going in the day is incredibly helpful just to get out and do things. Exercise itself probably really helps elevate mood, but it's also really, it's really important to adding structure in the day, and it really is an important adjunct for depression treatment really for all ages. And then I think psychotherapy has a role as well. It really absolutely does. There used to be 20 years ago, there was a debate that I think is a nonsense debate today. At least it's a nonsense debate today, which should an individual with depression have psychotherapy or medicine? It's never either or, it's always and. The best studies show that actually the best response is psychotherapy and medication, and psychotherapy and medication have individuals who have it are less likely to have a relapse from the depression as well and stay better longer. And psychotherapy, there's different kinds of psychotherapy that can be incredibly helpful. It can be supportive psychotherapy, problem-solving psychotherapy, cognitive behavioral psychotherapies, different kinds can be very useful. Yep.
Do you see in older adults that they more lie about their symptoms than younger people would, and how that would maybe the more talking to people more?
So the question was, do older adults lie about their symptoms more and you need to talk to their family more? Okay. I don't think they lie more. I think that they very often don't believe me when I tell them that they have a depression, though, because when people think of depression, first of all, the problem with depression, kind of with a big D as an illness, is that it sounds like depression with a little d. So depression with a little d is a normal mood. We've all had times when we feel crummy. Something's happened that disappoints us or gets us upset or that we feel sad about, and it's transient. And people who have little d depression can be cheered up. Something happens and your friends take you out, your family comes by, and they do something you enjoy, you can be cheered up for a while. So little d depression is associated with sadness. Depression is an illness with a capital D. You're not necessarily sad. You might not be sleeping well, you might have a lot of physical complaints, you might be losing weight, you might not have energy, and you might lose pleasure in things, but you might not feel sad. So I very often have to do a lot of education to say, yes, this is an illness. This is due to your depression. It's an illness. Even though it sounds like a normal everyday mood, this is quite different. And family members need to understand that, really need to understand that too. And need to understand that the individual is not deliberately not wanting to do things, that it's really coming out of an illness situation. Or not, yes?
Do you know of any research regarding the use of like brain scans or diagnostic tests for mental illness?
Using what?
Like brain scans?
Brain scans?
Yeah, or just kind of like, I know that with psychiatry, it's mostly verbal as far as diagnosing these illnesses. Do you know of any other diagnostic tests?
Yeah. Depression is a clinical diagnosis done by interview and history. There is no brain scan. I mean, we know the brains are different. We know the brains are different, but it doesn't show up on any MRI or PET scans or any of the most sophisticated scans that we have now. I mean, we know the medications we give. We know electroconvulsive therapy. We know transcranial magnetic stimulation are changing activities in neurons and brain cells. They don't show up on any brain scans. When I was training and I was a resident, there was a really popular blood test that we were often giving that seemed to have some association for diagnosing depression. Over time, continued studies have shown it's not reliable, and we don't even do that anymore. So even though it is a brain disorder, there's no question about it, it's at this time, in 2015, it's a clinical diagnosis based on a clinical interview and a very careful history. Okay, yeah.
This can get complicated, but just briefly, could you discuss the issue of alcohol, problems with alcohol orders, and all the times that can be related to depression? Do you see that where that's actually a landscape for the depression,
Oh, wow, this is another talk. Okay, so she asked the question. Wow. So she asked a question about alcohol in older people and its association with depression. So the two most common substance abuse problems in older people are prescription pain medications and other prescription medications and alcohol. Yes, alcohol is a problem, and alcohol always worsens depression. Alcohol is a central nervous system depressant, and it makes depression worse. The other thing that alcohol does is it completely disrupts and sleep cycles, which are incredibly important for recovery for depression at all ages. It's very important to have a good normal sleep pattern, go to bed at the same time, wake up at a normal time. So when I have older patients and they're drinking, I have to be very frank with them and tell them they really need to stop drinking. What's often shocking to my older patients is that a problem with drinking in an individual over the age of 70 is more than one drink per night. And they often don't believe me, because some of them have been enjoying a couple of drinks a day or some wine, and they've been doing it when they're younger, and when they're younger they might have been able to do it and enjoy it, but over the age of 70, more than one drink is considered problem drinking, and it always makes depression worse. And it interacts poorly with antidepressants, and it makes it harder for individuals to get better from depression. So that would be another talk, but you're right to bring it up.
Well, I think due to time, we're going to have to stop now, but I'd like to thank Dr.
Thank you very much. So I do want to leave you with the last thought that depression is treatable and it works, and there's nothing more gratifying than helping an older individual or someone in any age sort of regain their life and the quality of life that they really deserve. So thank you for being part of that.